Welcome to Glow for Hope, sparking conversation on mental health, where we break the silence, build community, and ignite hope. We're here to talk about what really matters: mental health, wellness, and the conversations that help us all feel seen and supported. Every episode will bring real stories, expert insights, and practical tools to help you navigate mental wellness and suicide prevention. Because together, we can change the conversation. Let's get started.
So today we are honored to speak with Rachel Jackson, founder of Project Compassion NFP, a Belleville, Illinois-based nonprofit dedicated to serving the unhoused and low-income community. Since its founding in 2005, Project Compassion has provided food, clothing, hygiene supplies, housing assistance, and compassionate care to thousands of individuals and families facing hardship. Rachel's vision has always been to bring dignity, hope, and resources to people who are often overlooked, and her organization has become a vital support system in the region. Rachel holds a BS in Business Administration and a MA in Philosophy and Professional Counseling. She is a certified master trainer in life skills and self-esteem, as well as a certified civil and divorce mediator. She also is a certified trauma-informed care and mental health trainer and clinician and instructor for mental health first aid. Now, with mental health and suicide prevention being pressing issues, particularly for vulnerable populations, Rachel brings valuable perspective on how homelessness and poverty intersect with mental health challenges and how her team responds with compassionate care. Thank you so much for joining us today, Rachel.
You're so welcome. Thank you for having me.
You're welcome. Now, you've dedicated so much of your work to serving the unhoused and low income communities through Project Compassion, and we'd love to hear a little bit more about the unique challenges that those populations face when it comes to mental health and suicide prevention. So, my first question for you is, with respect to mental health and like suicide prevention or suicidal ideation, what are the most common unique stressors that your unhoused or your low income clients experience, and how do these challenges differ from other clients in maybe more stable situation or have more stable resources?
Yeah, so the primary thing one of the things that we often see is access. So a lot of the unhoused, low-income individuals that require any type of mental service support, they have state insurance, and that is just not widely accepted throughout. And where it is accepted, there is such a wait list that I mean, if they're in crisis, then of course the first thing they'll do is go to the emergency room. You encourage them to do that. But just that long-term care, the medical management, any prescriptions, things like that just tends to fall by the wayside because they don't have access to it. Whereas if someone who has health insurance, of course, there is a easier access to getting appointments or even just being available for the wait or having what's needed. Stability gives them the affordability to be able to just kind of keep calling around and looking for someone to take in their insurance company. With state insurance, you don't have that affordability at all.
What are some of the wait times that you have seen, or can you tell me any average on how long compared to private insurance compared versus state insurance folks are having to wait?
Oh, goodness. It could go anywhere from 30 to 90 days. There is a huge gap, sometimes 6 months. It's just depending on the clinician and the specialty. Sometimes the trauma is severe to where they need to see a clinician that does specialty in trauma of some sort. And unfortunately, it's just not as easy as getting in because so many assessments are already needed prior to that particular client going into distress. So it could go anywhere from 30 days to 6 months, to be honest.
Wow, that is definitely something that needs to be fixed.
Mm-hmm.
And I know
Yeah.
y'all are working to fix that. So my second question for you is, when you are working with someone and you recognize some signs, what do you do? How do you coordinate with your local suicide prevention organization? And how does that referral process typically work? I mean, you're certified to work with through a lot of this. So when you see someone that's having a crisis, what do you do?
Yeah, so crisis work is very, very you almost have to be intentionally aware of what you're dealing with the crisis. So it's really important to see if there's any stabilization that requires immediate medical treatment, right? And so what we always do, if it is, then of course you're going to get that particular client to go to the emergency room, go to a mental health facility. If it's a manageable crisis or something that you're able to create some form of stability in the emotional effects that you're seeing, then at that point you could do a referral. One of the beautiful things about the work that I'm able to do is just the relationships. I've personally picked up the phone and called clinicians because let's just be honest, there is that access and that privilege of being able to reach out to another clinician, explain the severity or explain the situation, and do a gentle handoff. Even if they have state insurance, they're willing to take it on behalf of the referral that's coming through Project Compassion. Being able to do that gets them at least immediately screened, maybe 10 to 30 days worth of medication to just start trying to see if they need that. But if it's just a crisis that has been able to be managed, does not require any high level critical care, then we're able to definitely assess and then pass the referral over, but continue to do therapeutic services with some underlying trauma support there, and then get them into the higher services as it pertains to any type of medication that's needed, another level of maybe they're already on medication and it needs to be increased, or just identifying how severe the trauma is and how it's impacting their overall behavior and emotional stability.
So kind of getting to that before you actually reach that crisis point, because I've seen you work and I know how you work with your clients and how involved you are. And tell us about how important that is, because that relationship, forming that relationship, because as you said, you're dealing with a set of the population that sometimes feels
Hmm.
overlooked or sometimes been
Yeah.
treated very poorly and very, people are judging.
Hmm.
How important is getting that relationship in there to kind of find something early before you get to the
Yeah.
crisis point?
So, one thing that when you're dealing with the marginalized community, you're recognizing that there is a stigma about mental health. Oftentimes, when they are placed on medication, maybe at a young age or in their adulthood, they didn't feel right, or just the stigma of going to a therapist. So, I always do informed care, understanding the difference between the therapist and the psychiatrist and who does what. I'm also asking them to trust me, a trust that what I'm seeing does require something that is next level supportive care in their mental health. Answering the questions in a safe space, seeing that if I'm dealing with someone from the Black or Brown community or someone that is not of color, and just helping them understand that going to see a therapist, talking to a psychiatrist does not define you as crazy, air quotes,
Hmm.
but there means that is no different than breaking your arm or having some type of physical ailment that needs some serious treatment to it. So it's building that trust by informing them, breaking down the terminology, working with children and just helping the parents understand. Some parents think that therapists meant you're going to give them medication. And it's like, that's not therapy. So understanding that in crisis mode, there's a lot of panic. There's a lot of anxiety. There's that feeling of uncertainty. And so it's finding key points to interject and bring in that support. And also saying, hey, you've made the first step in getting coming in crisis mode. Let's take a second step and see how much further we have to go. And recognizing that if we get to a point where medication is needed, if we get to a point where inpatient services are needed, it's all about making you feel better. And so understanding that I am on that journey with you. Like I'm going to follow you through this. I'll be with you through that process. So it's helping them know that they're not, it's different. No one's going to just
Hmm.
give it to you now and you don't have supportive services, but you have that supportive service with you now.
Can you talk a little bit about the the stigma, especially within the minority community, especially in the Black community, why sometimes you get so much pushback when it comes to mental health and the history behind that? Because it's not
Mhm.
all, just rooted in it. There's some legitimate things that have
Absolutely.
happened. Can you kind of tell us the history and why in our community it's an issue maybe more so than others?
So in the African American and minority communities, there is that stigma of generational trauma. It's where something has just truly been passed down from one generation to the next generation in the family. If we're all honest, everybody has that, again, air quote, family member that was labeled as crazy and behaved in a way to where they were either black sheep or they were isolated from their family, or when they came around, there was so much destruction. But what we don't help them understand is if there's a relative that has mental health in your family, then it could be hereditary. There could be a gene that you could be carrying that could very well be triggered by your own life experiences. Then you begin to show signs and symptoms. So it's about understanding that this label of crazy has been placed in this family dynamic that has carried on for generations to generation. And then if you do get medication, oh, that means you're really, really, again, air quotes, crazy. And so it's about knowing that this is just what has been learned, a learned behavior, that there's a stigma around mental health and what it looks like and sound like. And the words and the labels have been so loosely used that you almost have to go back to the basics of creating a proper terminology around mental health so that an individual understand that there's no such thing as crazy. Mental illness is no different than, again, a physical illness where instead of your body not being whole self not being well, it starts in the mind and helping them understand how it's affecting their physical self. So it's just this generational trauma of passing down what is believed to be mental illness and the negative labeling that's been put on it from anybody that has received treatment or not received treatment because of it.
Right, right. That was a beautiful answer. This is so true. And let's talk about your okay, I want to go into the myth of like the strong woman because you know
Hmm.
you deal with a lot of moms, a lot of single moms juggling a lot. So when you see, someone we're worried about housing, worried about transportation, worried about food, how can you get them to worry about them,
Hmm.
themselves, and their mental health?
Yeah, absolutely. And so that's the beauty of what we do here at Project Compassion is to try to work with those basic needs first. Like, what can we immediately take off to help you? Because understanding that if you're not well mentally and emotionally, then you're no good for your children. And any mom that is really out here advocating for their children understand that language, right? So if you break down or if you go into crisis mode mentally because you're stressed, who's going to help you? I found just sitting and allowing a mom to talk out what's on her plate and to vent about it typically relieves some instant, like I'm heard, right? And then to move into action of showing that support then allows them to feel like they have okay, I have some support to move to the next level. But understanding that without you being mentally well, your children now will be in whose care? Now you're
Right,
helpless because your body has gone into forced shutdown mode. And most moms don't want to hear that. They don't want to know that you can either do willingly self-care, you can on your own surrender to your self-care, or you can allow your body and your mind to send you there, and then you have no control on what the recovery could look like.
right. So true. Now, once you have push past those challenges and those objections and you have someone who says, okay, I'm
Hmm.
ready to see someone.
Hmm.
Now, what if, they're worried about someone that's going to be able to understand their experience? How important then is finding the right clinician and for providing or finding, a clinician that understands their unique situation? How important is that? And that would bring me to the question basically of clinicians of color specifically.
Yeah, that is extremely important. If a person does not feel connected to their clinician, if they don't feel like they have that right connection, it's just the treatment's not going to go well. It just it's just not going to go well at all. The services won't go well. So I tend to do somewhat of a personality analysis when I'm talking to a potential client, understanding their dynamic. Again, what is the level of their trauma. You don't want them to regurgitate all of their trauma, and now you have to deal with the trauma, but you're not equipped. It's getting some high level assessment to say, I know who they can talk to. And so then for me, it's about keeping that clinician toolbox full with clinicians of color, with clinicians of specialty of color, to be able to do referrals to say, I have someone for you. It's also recognizing that if this person doesn't seem like a good fit, maybe we could do this person. And typically I'm pretty spot on with the connections because again, it comes down to that personality and that need. So if I know you understand my need, I connect with you better. If I
Right.
don't feel like you understand my need, I'm not going to connect. And so, most clinicians, when you find out what the underline is, if you put them with someone of specialty, that person can hear them, understand what they're going through, and then be able to service them, and it works out well. So, it's very, very important. If it's someone that is just looking for a clinician of color, saying, hey, I want to get into therapy, I've been experiencing some manageable symptoms, but I need some support, I always tell them to go to Psychology Today. And I jokingly say it's build a therapist because you can check the box. You can say what you want. You can say,
Right.
the specialty, and then it'll bring up everybody that service that area. But if for some reason, let's say it comes up and it's a group, I encourage them to call and ask, is there a clinician of color on staff? Is there someone who I can see, and sometimes they may have them, but they're not on the website. There's just the face of the primary clinician that is on the face of the site.
So, if you had to say anything to new clinicians coming in to practice, what are some of the most important things that you would want them to know so that they can help all people, especially the marginalized?
Absolutely. So become as well informed about culture and how therapy affects various cultures, as well as get if you're in a clinician role, get your specialty. Like continue to build out your certifications and your trainings in that role so that there isn't a wall now. You can only service them to this point and now they have to switch. So definitely building up certifications and certificates and getting immersed in culture and understanding various cultures, especially African American communities, especially understanding communities of Hispanic, because it's understanding how they're going to even respond, understanding that you may go in and that first session is nothing, like nothing. It's always especially with young kids, young adults, they don't want to talk to you. They don't want you to talk to them. So you can't always start at the initial symptoms, but you do got to find a way to connect in a way with them. And some of it is just being honest with, you know what? I know I'm not of color. I know I'm not. And so I may not be able to reach you, but I would like to just understand your viewpoint and your perspective. So what you're saying as a young clinician is, let me hear what you have to say. Then you can then invoke the DSM and all of the medications and all the things that we've been trained to do. But you first got to let them know that you can hear them and understand them from an emotional, because you cannot relate from a race standpoint or even culture, but you could understand just from a mental and emotional standpoint.
I love that. That's a beautiful answer. How do you feel the the training and the schooling, the education of clinician is handling cultural awareness and things along that sort? How do you feel that's going, um, just in the education process of young clinicians?
So I've probably been out of school 8 years now. But I will say that when I was in school, there was a lot about cultural norms, social and cultural norms. There was also a lot around diversity. And so, what I did find was to truly, truly understand some of the rooted trauma and generational and racial trauma, systematic trauma, there was outside training I had to do. So, shout out to CEUs because those are the things where you're constantly seeing it come up and you're able to educate yourself and go down. And sometimes you just have to go out of pocket and go through your own series of courses just to get a better understanding of what's out there. So I definitely graduated and was schooled at a time where understanding cultures and understanding norms and understanding ethnic background was very important in clinical work. So I think that is really important to what we do. And if it's not being taught, you still are responsible for going out and educating yourself in some form of training or certificate.
So your CEUs, that's your continuing
Continuing
education.
education, we are required to have those and turn them in when we renew our license. So again, you're always learning, and trust me, it doesn't. You look up and now you got to really deep dive and get more and more. And so the beauty is you can kind of shop around to your CEUs, and then by getting those, you're now being educated. And you're getting your CEUs to go towards to maintaining your license. So it's definitely beneficial.
Yeah, that's amazing. So you can, you come out of school, you can also find your CEUs, something,
Yes,
for suicide prevention, something for
yes,
marginalized community. There's something for everything, and
absolutely.
you're just continuing to keep learning.
Absolutely. And so even if suicide isn't your specialty, you still need to be aware of what it looks like, what it sounds like, what it may present as. I can't tell you how many assessments I've done and just simply saying, roll your sleeves up. For a teenager to show their arms after they've denied any cutting, any thoughts of suicide, any thoughts of self-harm, and there we go. So now there's a safety plan we need to put in place. Now I'm going to have to reassess how severe some of your symptoms are, and then of course making the proper notifications to ensure that you are safe and that you're not going to harm yourself or even others. And so that comes through just continuing education, understanding what that looks like and what that sounds like, and not being afraid of hearing it, because it could be hard to understand it. We're often trained to guard ourselves from things that we can and cannot handle, but I think that you do have to have some level of understanding of all components of individuals, therapy, and mental health in order to be effective in this work.
I think that was very important what you just said, because I mean, let's face it, if we have someone who has kind of gone through the system,
Hmm.
you get to a point where sometimes you know how to game the system, or you
Yes.
think you know how to game the system. You know what questions not
Hmm.
to say yes to.
Hmm.
And so it's extremely important for the clinician to be able to go
Yes.
off book,
Hmm.
off script,
Yep.
and look, that's I love that. I love that
Yeah.
you
Yeah.
do
It's
that.
and for me personally, there's that moral compass. There's that if I'm going to do the work, I got to be able to go to bed at night. And so
Yes.
I don't want to just say I checked pages and wrote and signed and did things just to do it. I want to definitely know that if the event something should ever happen, it's definitely that piece of me that can say everything was done, and then of course ethically, but I think that morally for me is maintaining the integrity of what I do and knowing that if I am in this field, I'm looked upon as an expert of service, and I do want to provide not only expert but excellence. And I know that being able to really get a thorough understanding of mental health and how it affects them with harming or self-harming, it's important. It's important to be able to kind of step over a line of saying, let's just roll over. Listen, if it's nothing there, it's nothing there. Okay. But if it is something there, then we need to address that.
Right, right. So let's talk a little bit about Project Compassion.
Yeah.
So, how does Project Compassion specifically advocate at the community or policy level to improve, access to mental health care and to ensure that your clients' voices are included in these conversations?
Well, I think for me, the biggest thing was becoming a voice in the face as a table as an African American clinician, being able to give the impact of it from the level of being
Yeah.
an African American, and then being able to say what really works and does not work in our community just through the community work that we do, working in the schools and working with the women and seeing the children and what really reaches them and what does not reach them. And then anytime something is being done that I don't feel is going to be a benefit to our community, again, not being afraid to be that voice at the table to say that that's not going to work, or that's not working, or how about trying this? And again, coming from that lived experience of being an African American woman living in a community where there was mental health in my family, and it was labeled as something else, and but just understanding just how severe that is, and understanding how it's important to have the conversation. I think everyone, my cousins, and actually all the cousins, like, we're not afraid to talk about mental health. We're not afraid to talk about trauma, and to compare it now to what we saw growing up, like, that was like, really, that was normalized. But
Yeah.
recognizing that nothing about that was normal. So I think our generation kind of broke that cycle, you know. And
Yeah.
so yeah, so
I would
they,
agree.
yeah, we broke that cycle, and we're not afraid to, say, yeah, I'm gonna go talk to somebody. Or, you know what? I'm so angry. I think I need to call a therapist. We're not afraid to do that because we have been able to experience it.
Yeah, we had, yeah, I identify so much how we had, oh, Uncle so and so,
Yeah.
just and they just the oh, he just a little off, he just
Mm-hmm.
like just stay in his room
Yeah.
or what have you. And we have to be like understanding about the fact though that some of our ancestors did go through some
Hmm.
things that have been passed down that make us kind of afraid to
Yeah.
seek treatment. I
Yeah.
mean, we have to realize that. And I think some clinicians may not be aware of some of the history as far as testing and things that had happened to African Americans
Mm-hmm.
that really make folks still to this day kind of
Yeah.
wary. And
Yeah.
that's really important to understand that.
Yeah. And understanding what it means to take medication. Like, typically the history is we take medicine when we're sick, and so now you're telling me I need to take some medicine all the time. So it's just understanding that, often explain, like, we have things in, like, chemical levels in our brain, and sometimes the medicine just brings it back up for us. It's not about being sick, it's not about being well, it's about saying my chemicals need a boost. And so just trying to present it in a more empowering way and impactful way that helps encourage that openness to want to go and learn, and be a part of mental health services to help them get the treatment that they need.
So finally, what advice would you give to someone who notices signs that a friend or a family member or a coworker or a community member, somebody may be in crisis?
Mm.
What steps should they take like right away, and what are the things that they can do?
So the dynamics in all of those is very different, just simply because of the relationship.
Hmm.
When there's, a family member in crisis can be approached totally different than a colleague that's in crisis. Both can be handled with compassion and care of first, acknowledging to them that you see that they're maybe not, they may not be themselves, or saying, hey, how did that impact you? And this happened, you went through this, or tell me how that really impacts you. I always say we can check our pulse. In other words, do a pulse check. How you feeling today? What's your mood today? And then just understanding that, again, as a first aid mental health instructor, one of the things that we are trained or understand to do is, mental health crisis require immediate reaction. And so if it's, again, a severe crisis, then immediately get whatever medical professionals in place to do so. If it's a crisis, then you can then set up maybe a plan with them. If they're able to tell you what's going on, say, okay, here's what we need to do. Just walk them through some steps. Every crisis requires stabilization. You always want to stabilize. You always want to stabilize within your capacity, within your training, and within your RAM. So you don't want to make a bunch of promises, right? I'm gonna call you all night, every 2 hours. No, you're gonna go to bed because you're tired, and you're not gonna call that person. Now you've broken your promise, right? So you want to make sure that you're not inserting yourself so much that you then trigger other codependencies and things like that. So the family dynamic, friend, colleague is all different, but I say the primary thing is to stabilize. Everybody needs to be stabilized, and then the relationship will determine how much further you go in the approach.
Right. And then I was hearing boundaries in there as well, as where you say, okay, don't make promises that you
Don't.
can't keep. And yeah,
Mm-mm.
like you said, the codependency, there have to be some boundaries in there because
Hmm.
yes, you want to help, but there are things that you may not be equipped to deal with, or there
Yep.
may be things that are actually triggering to you.
Yeah, very much
Yeah.
so. Very much so. And we see a lot of that in the education field where students trigger teachers or trigger administration because sometimes we don't deal with our trauma. We just keep going and living and thinking we're okay. And then you see something that you identify with from your childhood or from being a teenager. And now you go all in and it could not be as helpful as you think it is because you can be therapeutic without being a therapist. But it's understanding that you go in immediately saying, we are going to get you the help you need, not trying to identify as being the help,
Right. Yeah, that's
not being
true.
the help, but saying, I'm going to get you the help that you need.
What would your advice be for volunteers? I know I said finally, but this was an important because we have a lot of volunteers
Hmm.
and you have a volunteer you deal with a
Hmm.
lot of volunteers.
Hmm.
How important is it for volunteers to recognize where they're at on their healing journey before they reach out to try to help someone else?
Every volunteer, every agency should always put their volunteers through some form of trauma awareness training. That is the primary thing. Make them go through as part of onboarding, because what happens now is they can become aware of signs and symptoms that may trigger them, as well as hearing that make okay, this is where I think I am, and now encouraging them to not, interject themselves or connect with someone because it's called trauma bonding. So you're going to bond over the trauma that you see, you feel, that you relate to. And you don't want to trauma bond and say, oh, I know how to handle this because I've gone through it. Well, just because you've gone through it doesn't mean you healed. You could have healed incorrectly. If I fall out of a tree and break my arm, if I don't go to the doctor, my arm is still broke. It'll eventually heal, but it may not be as functional as it would have been had I gone and got the treatment. The same goes with mental health. You go through something and now you learn how to manage, but your coping skills and your coping mechanisms and your resiliency, your internal build may not be that of that client, and you could definitely mislead them, misguide them, or again create that codependency trauma bond. Now that person is relying on you for everything that they are going through emotionally, and it can really become disruptive to not only the organization but to your life as a volunteer.
Yes, that's so important. That's so important.
Hmm.
Yeah, with the onboarding process, that has to be
Hmm.
done. So we're going to take the last few minutes to ask you to tell us a little bit more about the needs of Project Compassion. What do you all need? What can the community do to help you continue the amazing work that you're doing?
Well, thank you for that. I think the biggest thing is just awareness, letting people know we are here servicing homeless, low-income women and children ages 19 to 20, I'm sorry, 19 to 30 mothers. And then we work with youth and infants and youth ages newborn to 12th grade. Basic need items. We have a cafe set up. We have a pantry. We have a diaper bank, formula bank. We offer free therapy services to that age demographics. We also offer any hygiene supplies that's needed. And then we have a free laundry facility where they can come in and wash 2 loads of laundry every week. Clean clothes are important to self-esteem and just feeling like yourself. And so the awareness to the community that we're here, and then just anytime anyone would like to volunteer or be a part of any services that we have, we always welcome that. We are a 501c3, so any monetary donations or in-kind donations are welcome as well.
And where can they find you?
So we are at 6609 West Main Street in Belleville, but you can find us online at projectcompassionNFP.org.
And you're on all the socials, right?
On all the socials at
All the
Project
socials.
Compassion, yes.
Okay. Rachel, thank you so much
Thank
for your
you.
time and for your incredible work. I have known you, full disclosure, for A lot of years,
A lot of years.
many, many years, and can attest to the great work that you do. And I'm
Thank
just
you.
so proud of you and to
Thank
see
you.
how Project Compassion has grown and how
Thank you.
you have grown at doing this work. So thank you
Thank
so much
you.
for your time today, and
Thank you.
we appreciate it with the Glow for Hope podcast.
Thank you. I appreciate you guys and the work you do. Thank you.
Right.
Thank you for joining us on Glow for Hope. If today's conversation resonated with you, share it with someone who needs to hear it. Remember, your mental wellness matters, and you are never alone. For more resources and support, visit glowforhopenfp.org. That's glowforhopenfp.org. Stay connected, stay hopeful, and keep the conversation going. Until next time, keep shining.
This podcast does not and is not intended to provide medical advice. The information presented on this podcast should not be interpreted or construed in any way as a replacement or substitution for medical advice. It is important that you discuss your condition, treatment options, or any questions that you may have with your doctor or healthcare provider.